Good morning, everyone. My name is Dr. Ali Calik, and I am attending from Istanbul, Turkey. Thanks for the opportunity to the faculties for giving me the presenting this challenging case in the scientific and prestigious environment. I would like to present a case about left internal mammary artery to pulmonary artery and successful treatment of this fistula formation with transcatheter coil embolization. My case is a 53-year-old man, and he admitted our outpatient clinic with typical exertional angina and shortness of breath. In his relevant cardiac history, he has a coronary artery bypass graft with 2 vessels in 2009, and his lima was grafted to the LAD and ramus artery sequentially. Additionally, in his history, he has diabetes mellitus and hypertension over a decade. On his admission, his transthoracic echocardiography revealed a left ventricular ejection fraction of 50% and grade 1 diastolic dysfunction with segmental valve motion abnormality. We proceeded with a coronary angiogram and which demonstrated a right coronary artery with diffuse plaque formations and critical stenosis of native ramus artery. And selective angiography of lima demonstrated a large fistula formation originating from proximal part of lima and draining to the pulmonary artery. So we consulted our patient with CT surgeons in our hospital, and we decided to completely revascularize our patient with stenting native ramus artery and occluding the fistula formation in the same procedure. In the beginning of the procedure, we stented the ramus artery with a 3/15 drug-eluting stent, and then we go through to occlude the fistula formation. How we did it? We engaged the lima with a 7 French EMA catheter, and we advanced the PT2 guide wire to the distal portion of fistula. And then over this guide wire, we advanced a 2.8 French microcatheter to the mid portion of fistula. After that, our initial strategy was embolizing the major 2 side branch of fistula individually, but unfortunately, the first coil was embolized distally inadvertently, and the second and third fistula, the second and third coils were unable to occlude the fistula formation. So in the procedure, we changed our strategy and we tried to deploy another 3 larger coils to the main branch of fistula. And at the end of the procedure, after waiting a few minutes, we confirmed that occluding the fistula formation and blocking the all blood flow, and ended the procedure without any complication. Lima to pulmonary artery fistulas can be acquired or congenital, and the acquired form of these fistulas can be secondary to trauma, neoplasm, or inflammatory disease. And the predisposing factors for the development of fistula include injury to the pleura or parenchyma, incomplete ligation of intercostal branches of the lima, the use of electrocautery instead of ligating side branches, and operative side infection and inflammatory process leading to neovascularization. The most often reported presenting symptom is recurrent angina, and the underlying pathophysiological mechanism is substantial blood shunting from the lima to pulmonary artery, resulting in coronary still phenomena and myocardial ischemia. We have a few options for therapy, for treatment of this, to manage this clinical entity. And this can be listed as conservative medical therapy, surgical ligation, and endovascular therapy. And endovascular therapy options can be listed as coil embolization, vascular plaque embolization, and cover stent implantation. Which patient should we intervene is an important question for this clinical entity, and the answer should be based on the patient's symptoms and the characteristic of fistula. The patients who are asymptomatic and who has small fistulas or who has high surgical risk and who doesn't have a suitable anatomy for the endovascular intervention can be followed up by conservative medical therapy. But, however, if the patient has coronary still phenomenon, angina despite optimal medical therapy, congestive heart failure symptoms because of these fistula and aneurysmal dilatation of fistula, these patients should be intervened either surgical or endovascular. Type of interventional therapy depends on the surgical compatibility of the patient and the anatomy and the characteristics of fistula. However, the surgical ligation is not the first option for nowadays because thoracotomy carries a significant risk for morbidity and mortality. And for nowadays, endovascular therapy options emerge and are now alternative to surgical treatment. They are less invasive procedures. They provide decreased procedure-related risk, lower cost, and shorter hospital stays. When deciding type of endovascular therapy, it has utmost important that physician and institutional experience. The most commonly used two techniques are coil embolization and vascular plug embolization, and these both techniques has pros and cons. It can be listed as for the coil embolization. Coil embolization is used for smaller fistulas. They are inexpensive methods. They need smaller catheters and they are low profile device and they are easy to deliver. But the Achilles heels of this technique is distal embolization and higher recanalization rate. When it comes to Amplatzer vascular plug embolization, they are used for larger fistulas when compared to coil embolization. But they provide more accurate placement and less distal embolization and recanalization rates. But the drawbacks of vascular plug embolizations are they are expensive methods, they need larger catheters, they have rigid catheter release wire set, and the delivery and deployment in tortuous vessels may be challenging in some cases. In conclusion, limatopulmonary artery fistulas are really rare clinical entities that can develop after bypass grafting, and they should be kept in mind as a rare cause of persistent angina. Selective angiography of lima is important to diagnose this entity, and the vascular treatment options have been successfully applied for treatment of this order and now are the first-line therapies. Type of endovascular therapy depends on anatomy and characteristics of fistula and physician and institutional experience. Thank you for your attention.